Can you explain the significance of cardiac troponin in the context of attention pneumothorax? Additionally, when and how many ribs are typically involved in a flail chest?
Cardiac troponin is a highly sensitive and specific biomarker for myocardial injury. While it is not commonly elevated in isolated cases of tension pneumothorax, severe hemodynamic compromise due to elevated intrathoracic pressure can lead to decreased venous return and coronary perfusion. This may, in extreme situations, cause myocardial ischemia and secondary troponin elevation. The rise, however, does not reflect direct myocardial trauma from the pneumothorax itself, but rather a physiological consequence of impaired perfusion. In the context of flail chest, this condition typically involves 3 or more consecutive ribs fractured in at least 2 places each, resulting in a free-floating segment of the chest wall. This segment exhibits paradoxical movement, collapsing inward during inspiration and bulging outward during expiration, which impairs respiratory mechanics and contributes to hypoxia.
What percentage of oxygen is typically delivered by a non-rebreather mask?
A non-rebreather mask, when properly fitted and supplied with oxygen at a flow rate of 10 to 15 liters per minute, typically delivers a high concentration of oxygen, ranging between 60% and 90% FiO2. Although it is theoretically capable of delivering close to 100%, practical factors such as mask seal and air entrainment usually limit the inspired oxygen fraction to below that.
How would you manage a case of breech presentation in an emergency setting?
Management of breech presentation in an emergency depends on multiple factors, including gestational age, the type of breech, and both maternal and fetal condition. In a pre-hospital or urgent setting where delivery is imminent, the priority is to ensure maternal safety and facilitate spontaneous delivery without traction. The mother would be positioned appropriately, often in a lithotomy or all-fours position, and no forceful pulling would be applied. If the body delivers but the head is delayed, skilled maneuvers such as the Morrisseau-Smellie may be required, but only by trained personnel. Immediate preparation for neonatal resuscitation is essential. In a hospital, where there is time for assessment, external cephalic version may be considered if gestational age and fetal status allow. However, due to increased risks associated with vaginal breech delivery, particularly in first-time mothers, elective cesarean section is often the preferred mode of delivery. If vaginal breech delivery is pursued, it must be under strict criteria in a setting with surgical backup and experienced clinicians.
A patient who escaped a building fire is unconscious, and their nasal hair is wet. What is the reason for this observation?
Wet nasal hair in this scenario strongly suggests thermal and inhalation injury. The moisture results from condensation of superheated water vapor or steam inhaled during the fire, indicating that the patient has sustained upper airway burns. This is a critical sign of inhalation injury, which can rapidly lead to airway edema and obstruction. Early airway management, including possible endotracheal intubation, should be anticipated even if initial oxygenation appears stable.
Consider a patient presenting with chest pain, sweating, and diaphoresis. This patient also has a history of hepatic disease and is currently in SVT. What medication would you administer?
This is a complex clinical presentation that combines features of acute coronary syndrome, ACS, supraventricular tachycardia, SVT, and underlying hepatic disease. My initial priority would be to stabilize the airway, breathing, and circulation, and to obtain a 12-lead ECG to clarify the nature of the chest pain. Oxygen would be administered if SpO2 is below 94% or if there is respiratory distress. Intravenous access would be established promptly. Aspirin is critical for suspected ACS, and unless contraindicated by active bleeding or severe hepatic dysfunction, a loading dose would be given. Nitroglycerin may be administered for chest pain, assuming blood pressure is adequate. If pain persists, morphine may be considered cautiously. For the SVT, if the patient is hemodynamically stable, I would attempt vagal maneuvers first. If ineffective, adenosine is the next step. Despite hepatic metabolism, Its ultra-short half-life makes it generally safe even in hepatic impairment, although close monitoring is necessary. If instability occurs, such as hypotension, altered mental status, or persistent chest pain, synchronized cardioversion is indicated. Medications like beta blockers or calcium channel blockers must be used with caution in hepatic disease and ACS due to both metabolic and hemodynamic effects. Additionally, further ACS management may include clopidogrel, statins, and anticoagulation, but hepatic function must be closely monitored and dosing adjusted to mitigate bleeding risk. Cardiology input is essential, and management must be individualized to balance the competing risks.
Under what circumstances would aspirin be contraindicated for a patient?
Aspirin is contraindicated in several situations. These include active gastrointestinal or intracranial bleeding, known hypersensitivity to aspirin, such as bronchospasm, angioedema, or anaphylaxis, and bleeding disorders like hemophilia or severe thrombocytopenia. It is also contraindicated in children and adolescents with viral illnesses due to the risk of Reye syndrome. In cases of uncontrolled severe hypertension or severe hepatic impairment, aspirin must be used with extreme caution or avoided, depending on the bleeding risk and liver function. Additionally, in patients with a recent hemorrhagic stroke, aspirin is generally avoided unless clearly indicated by a specialist.
What are the contraindications for Penthrox?
Penthrox, or methoxyflurane, is contraindicated in patients with pre-existing renal disease due to its nephrotoxic metabolites. It is also contraindicated in those with significant hepatic impairment, known hypersensitivity to halogenated anesthetics, or a personal or family history of malignant hyperthermia. It should not be used in patients with reduced consciousness, respiratory depression, cardiovascular instability, or in situations of severe hypovolemia. Concurrent use with tetracyclines increases nephrotoxicity risk and is contraindicated. Penthrox should generally be avoided during early pregnancy unless absolutely necessary, and its use should always follow careful patient selection.
In the context of aspirin contraindications, which is a greater concern? Bleeding 40 days ago or hepatic disease?
In this context, severe hepatic disease is a greater concern. A bleeding episode that occurred 40 days ago, if resolved without ongoing risk factors, is not typically a contraindication, especially in urgent cardiovascular scenarios. In contrast, significant hepatic impairment compromises clotting factor synthesis and drug metabolism, increasing the risk of gastrointestinal bleeding and drug accumulation. Therefore, hepatic dysfunction presents a more active and ongoing contraindication compared to remote bleeding.
In a triage situation, you assess a patient whose airway is clear, but they are not breathing. What is your immediate action?
If the airway is clear but the patient is not breathing, I would immediately initiate rescue breaths to restore ventilation. This addresses the B component of the ABCs. If no pulse is present upon reassessment, full cardiopulmonary resuscitation, including chest compressions and ventilations, would be started in accordance with basic and advanced life support protocols.
A motor vehicle accident patient presents with active bleeding and complains of leg pain. What would be your course of action?
After ensuring scene safety, I would initiate a primary survey following the principles of airway, breathing, circulation, disability, and exposure, ABCD, while applying cervical spine precautions. The immediate focus would be on controlling the active bleeding using direct pressure, elevation of the limb, or tourniquet application if necessary. I would assess for signs of hypovolemic shock and establish large-bore 4 access for fluid resuscitation. The injured leg would be immobilized with a splint to reduce pain and further damage. Pain management would follow once life-threatening issues are stabilized. A secondary survey would then be completed to evaluate other injuries, and rapid transport to a trauma center would be arranged.
A patient has significant leg bleeding and is unconscious. What will you do first? Control bleeding or initiate CPR?
In this scenario, the first priority is to control the bleeding. Uncontrolled hemorrhage can rapidly lead to hypovolemic shock and cardiac arrest. CPR without addressing the root cause, severe blood loss, would be ineffective. Once the bleeding is controlled, I would then assess for a pulse and breathing, and if absent, initiate full CPR.
You have an accident patient with a GCS of 13 who is fully obese and able to follow commands. Their oxygen saturation is acceptable. How would you manage this patient?
This patient has a moderate head injury with added complexity due to obesity. I would begin with a structured primary survey, ABCD, while maintaining spinal precautions. Even with acceptable oxygen saturation, obesity increases the risk of airway obstruction, so I would be vigilant for signs of respiratory compromise and involve anesthesia early if needed. Breathing effort and chest movement would be assessed, considering reduced lung compliance in obese patients. Circulation would be evaluated for access secured and signs of shock monitored. Neurological status would be reassessed regularly through GCS, pupil response, and motor function. Imaging, including a CT brain and possibly cervical spine, chest, abdomen, and pelvis, would be warranted depending on the mechanism of injury. Pain control, positioning to optimize breathing, and prevention of pressure injuries are crucial. Continuous monitoring and possible transfer to a higher-level trauma center with neurosurgical and critical care capabilities may be necessary.
What are the reversible causes of cardiac arrest?
The reversible causes of cardiac arrest are summarized by the HS and TS. The HS include hypoxia, hypovolemia, hypo/hyperkalemia, hypothermia, and hydrogen ion accumulation, acidosis. The TS refer to tension pneumothorax, cardiac tamponade, toxins or drug overdose, coronary thrombosis, acute myocardial infarction, and pulmonary thrombosis, pulmonary embolism. Prompt identification and correction of these factors are critical for successful resuscitation.
A patient hit their head and is described as almost dead. Can you explain why this critical state might occur?
A head injury described as almost dead implies imminent brain herniation or profound neurological deterioration due to raised intracranial pressure. This can result from intracranial hemorrhage, such as epidural, subdural, or subarachnoid bleeds, or from cerebral edema. The skull's fixed volume means that any expanding lesion increases intracranial pressure, compromising cerebral perfusion. As pressure rises, brain tissue may herniate through structures like the tentorium or foramen magnum, compressing the brainstem, which governs respiration and cardiac rhythm. If untreated, this leads to irreversible brain damage and death. Secondary insults such as hypoxia, hypotension, or seizures worsen the outcome.
Finally, if a patient has both hands amputated, where would you check their pulse, and where would you connect a blood pressure cuff?
In such a patient, central or proximal peripheral pulse points would be used. The carotid pulse in the neck and the femoral pulse in the groin are most reliable. An apical pulse can also be auscultated over the precordium. For blood pressure measurement, a cuff would be applied to a lower limb, commonly the thigh or calf, ensuring the cuff size is appropriate for the limb's circumference to obtain an accurate reading.